talk about the role of medication in the treatment of trauma. It's important that we remember that medication, psychotropic medication, revolutionized the treatment of psychiatric disorders. Prior to medication, people lived their whole lives in institutions, didn't have much quality of life, often were subjected to terrible treatments in order to contain them, etc. The original psychotropic medications, such as Thorazine, etc., allowed for the possibility of deinstitutionalization, decrease of the more severe and inhumane types of treatment like electric shock therapy and keep people tied up and things like that. It allowed for the patients to have participation in the community and led to the deinstitutionalization movement. Of course, not enough supports in the community were created, especially at first, and even now there's more, but not enough. So institutionalization was not replaced by a rich array of help in the community. One of the results of that is that people with chronic mental health problems and often severe histories of abuse and trauma end up in jail. And there is a large psychiatric population in our jails, especially for people of color. And so it's like we deinstitutionalize from one sort of institution and institutionalize people in another sort of institution. There is treatment to some extent in jail, but not what you'd like to see. Probably if you went to do a trauma screening of the people who are incarcerated in jail, you'd find near 100% severe trauma survivors. If you looked at the ACEs of the people in jail, you'd see a high number. Of course, medication constantly continues to evolve, and you no sooner know the ones that are being commonly prescribed with your clients when more new ones appear. So that's good because they're getting more precise and better medications, plus people are always working on decreasing the side effects and increasing the power. But just keep in mind that medication is not an exact science. It's not clear you have this diagnosis and therefore you should get this medication. You, I'm sure, have already experienced from clients that people often say, even just take depression. They'll try one antidepressant and that won't work, and they'll try another. And it always takes a few weeks to know whether medication is working. Sometimes people find one that's just really makes all the difference in the world to their life. Our kids often end up on a whole cocktail of medications, 3, 4 very serious medications, because no one in itself achieves the results people are looking for. And it's often a trial and error. It's hard to explain all this to parents and or to the youth themselves, and to help them have the patience and the trust necessary to go with that process. Also, youth often feel like by offering them medication, we're trying to control them or turn them into somebody else, just trying to get them to be quiet. And this reflects their experience and their sense of not being seen, not being appreciated, but instead being a problem to other people in their lives. So they can see medication as a control instrument. And of course, in some cases, they're not wrong about that. So all the psychotropic medications that we use have side effects. Or, as I once heard someone say, side effects are just the effects that we're not primarily looking for. They're all just effects. Our early antipsychotic medications like Thorazine had a tremendous side effect of what is called tardive dyskinesia, which is involuntary tic-type movements of various parts of the body. What was horrifying about tardive dyskinesia is that it would not go away even after the medication stopped. they put, if people are using any medications like that now, they are also given another medication which prevents that particular side effect. So you get one medication to help with your disorder, another medication to help prevent the side effects. And that's also pretty common. The ADHD meds are known to have growth inhibition. That is, the kid doesn't grow taller when they're on ADHD medications. They also can inhibit eating. These two, of course, might be connected. Decrease hunger, and of course they can affect sleep, especially if given on a rhythm that results in disrupting sleep. A lot of the medications that we now use for depression, for anger, for acting out behaviors have a well-known effect of making people gain weight. And this is not a trivial effect, because gaining weight can affect the person in many ways. First of all, health, mobility, ability to participate in things like sports and activities, and also in terms of self-esteem and in terms of social acceptance. So gaining weight can be a huge detriment to someone taking the medication at all. People who have been on psychotropic medications often mention that they feel numbed out, or they feel that they have no highs or no lows, just sort of in a gray area, or they're sleepy all the time. And I'm telling you these things because these can be the reasons people are resisting their medication, or they take it for a while and then stop. What's essential for us as treaters is to understand that these effects are real, and to work with the person. It's not helpful for us to just say, oh, the medication helps you, it's wonderful, you should love everything about it. There's something wrong with you if you want to stop it. We can't make any progress in helping people accept the benefits from their medications if we don't validate and actually deeply appreciate what's hard about this. And maybe we can think about something in our own experience where we've had to take a medication that has helped us but has also had side effects. Like some people have had to take steroids, which have really helped them with the disease but have resulted in a puffed up face. That if we can get that compassion, that these are real things and real things that are very understandable not to like. So we want to validate, and we want to work with somebody about why are we being transparent about why are we suggesting this medication? What are the exact effects that we're looking for? What would be success? What are we expecting? In what way are we expecting this medicine to help them? And is that a goal that we both agree on? So let's say we hope that this medicine would help when they started to get angry, to give them a few minutes to pause and make a better choice of how they acted next. Well, if we could explain this, and if we could agree with the youth that yes, this is something that he also wants, then at some time period, like say after a month, we could evaluate, well, did this happen? Did it give you the effect that you and I agreed that we were looking for from it? On the other hand, another way is to stop a medicine and say, this is what we're concerned about. We're concerned that if we stop this medication, you will experience this. And so let's try it, let's see, and let's look in a month to see whether in fact you have experienced this. And whatever it is we're looking for positive effects or for negative effects of stopping it, let's chart them, let's track them. Let's have the youth, if they're old enough, track what's happened to them in the areas that we expect the medication to affect. And that way, first of all, it makes them develop more self-awareness and more ability to see patterns in their own behaviors, and it helps them take a more active role in managing their own symptoms. Because remember, this whole thing about medications, it's not a given. Many countries use much less medications than we do. The United States has much higher use of anti-ADHD medicines, But other countries also have a different philosophy, even with dealing with the chronically mentally ill, and use medications only when they're in a crisis, not as an ongoing stabilization. You can find out a lot about this. There's also groups that are advocates for patients that advocate for less medication. So again, like many things in our field, we have to really appreciate what the medications can give people and how important they can be. And also, we have to be skeptical and think about what is the use that we're putting these medications to. Because remember that, not surprisingly, medication use also reflects social conditions. It also reflects race. It also reflects access to health care. For instance, the use of ADHD medications is affected by what kind of school you have. I mean, maybe what we should be doing is not having classrooms of 30 kids all expected to stay together and be quiet all day. If they had more time to be outside and more individual adult attention and so forth, would they be less hyperactive? What if they had more sensory breaks and sensory experiences? So maybe we're trying to medicate kids to fit into a system that isn't really designed for kids. There are some kids that can fit in just fine, but if somebody has a more active body, is the solution medication, or is the solution giving them time to run around? So therefore, the more a school is under-resourced and has big classes and not enough staff and so forth, the more likely they are to see kids as pathological because the kids can't fit into this situation. Another prime example is foster children. Foster children are given 4 times the medication, as much medication, as children in their same circumstances with the same socioeconomic class, race, and symptoms. So it's almost to me like this is medication instead of love. If a person is surrounded by loving, supportive, regulating relationships and they have difficulty, the relationships help them with their difficulty. They may need some medication, but not nearly as much because they have love, they have support, they have adults who care, they have people who can help them get through whatever the difficulty is. Foster children are placed have a much more tenuous situation, and also they're blowing out of foster homes and people are in despair. What are we going to do with this kid? How can we raise them? And so medication to decrease their aggressiveness, medication to help them in school, medication to help them be less depressed. So again, what if we thought about how could we get these children more love and less medicine? Now, I'm really oversimplifying this because, of course, good people caring about foster children are already trying to get them more love, and we just don't have the resources, and we don't have as many foster families as we need and so forth. So it's not like this is a simple solution or a simple cure. But the fact that foster children are getting 4 times as much medication as children in their same circumstances who are in biological homes, it does teach us something. It teaches us that we use medication for more things than a medical condition. So we are often not only working with a team that's using medication, but almost entirely, we're always doing that, and we're often for updates to help make medications about decisions. We are also often in the position of being the one who is presenting the suggestion to the parents and who is expected to advocate for the medications. So what are we going to do about that as social workers? Well, certainly we need to learn about the various medications. What are they? The ones that are most common in our environment. What are they? What are they expected to do? And what are potential side effects? But probably the most important thing about this is to be respectful to the client and their parent, to understand what are your objections, what are you worried about, and to validate that those are real, understandable, loving worries. Sometimes the system, especially say perhaps a school system or something, could judge the parent and feel like, oh, this parent is just obstructing what we want to do, which is give the kid medicine. but maybe the parent loves the kid and has heard bad things about the medication or has reason to distrust authority. This especially might apply to persons of color who have the history of having persons of color being used for medical experimentation without their consent. So we might know we're great people, but other people don't know we're great people. So we want to listen. And when you're working with a child who says they can't stand a certain medicine and they're stopping it, find out, be specific. What does this medicine do that you don't like? I always wondered, all right, you're on 4 medicines and you want to stop one. How are you picking the one you want to stop? It could be as simple as that medicine has a bad taste in the child's mouth. One of the things to pay attention to and ask about is sleep. Sometimes people are given medication to help them sleep, but it's important that we know if our clients are having difficulty sleeping, and is this medicine helping them sleep better? Is it interfering with their sleep? Is it making them sleepy all day? Because that's a big factor to people's well-being, if they're feeling groggy all day and can't really think, that affects their well-being in every way. So we just want to be validating. We want to be respectful. We want to assume that what our clients are saying and what our parents are saying about the medicine makes sense, given their life and given what their experience. We want to take a collaborative approach and see whether we can agree on a goal and agree. First, we could agree, all right, we'll try it without the medicine. We'll give you this and that support. And if that works for you, then we don't need to go to the medicine. So if the medicine being prescribed is an ADHD medication, could we try having more lists, more visual cues, more help with homework, et cetera, et cetera. So let's try other interventions first. Let's agree on what we're trying to change and see if it's possible to change it without meds. And if we're starting meds or stopping meds, let's agree on what our goal is and check in on it regularly. Is this working? Kids can have med vacations. Sometimes kids go off medicines for the summer, which can help with their growth if it's an ADHD med. Sometimes they need the meds more in the summer because they're plunged into their family difficult situation. So we want to support the use of medications. They can be a lifesaver for people, but we also want to be careful, respectful, and collaborative with our clients in deciding which medicines and when and how, when to start, when to stop. And that will be your role. Thank you.